everyone. I hope everyone had a great lunch break. The next topic that we are going to be talking about today is hereditary cancer and genetic counseling in the Maritimes. This will be hosted by Kathleen BUCKLEY, who is a doctor in Nova Scotia. I will remind all participants and the people that will be joining in for the session itself that this is a live session that will be recorded. So please be mindful of speaking with the speakers itself and direct any of your questions to our chat. And we usually will try to leave 5 to 10 minutes at the end for any questions that may come up. So whenever you're ready, Dr. Buckley, you can go ahead.
Thanks very much. So just to clarify, I'm not a physician, I'm a genetic counselor, and I hold a master's degree in genetic counseling. So you can just call me Kathleen and that would be just fine, thanks. Also, I've pre-recorded my slides just to make sure that I stayed true to the time allotment here, but I will still be here to answer questions at the end.
Thank you for that. So sorry about that. And whenever you're ready, you can start your presentation.
Oh, are you not hearing it yet?
No, there's no audio on our side.
Okay, we tried this yesterday and we thought we had it set up, but it looks like we didn't get it quite right. So I'm not sure if Steve's there to help me with the audio. I know we set it up yesterday.
Hey, Kathleen, how's it going?
Good, how are you?
I'm fine. So just remember, we'll go to share. And when that share window comes up, you'll see the little tick box to make sure share computer audio is on.
Okay.
Oh, you have to unshare first. So we need to actually stop the share.
To unshare again. There we go. Okay.
All right.
So going to the share. And then remind me where I'm going again.
So it'll be sort of in the top left-ish part of the window. And it'll say share computer audio.
Computer audio. I thought that would be automatically checked since we set it up yesterday.
Yeah, no, it needs to be shared every single time.
Gotcha. Thanks very much.
Okay, no problem.
Okay, here we go. Good afternoon. So as you've heard, I have been working in cancer genetics for over 20 years, but I'm quite new to the Maritimes and joined the IWK team about 10 months ago. Our team includes 7 genetic counselors, some working full-time in cancer and others splitting their time with other areas of care. We also have 2 medical geneticist physicians and a number of support staff. So I'm really pleased to be representing this great team today to speak to you about hereditary cancer, genetic counseling and testing in Atlantic Canada. And there are many types of inherited cancer syndromes and not enough time to cover them all, so I'll focus on a general overview of the differences between hereditary and sporadic cancers and the different types of genetic testing that someone might receive as they move through their cancer journey, only one of which is specific to hereditary causes for cancer. We'll talk about the purpose of genetic counseling and what to expect from that service, help you identify situations where someone might consider genetic counseling and how to access this service in your area. We often use the words genes and DNA interchangeably, so let's break it down. Our bodies are made of billions of cells, and each cell contains a complete set of our genetic code, or the genome. And within each cell, our genetic code is organized on structures called chromosomes. Each chromosome is a long string molecule called DNA. And DNA is made up of 4 building blocks: adenine, thymine, guanine, and cytosine. The order that those building blocks are put together creates a code. And that code, it makes up genes. So each gene, and there could be hundreds to thousands of individual genes on each chromosome, each gene is a set of instructions which tells that cell how to make a particular protein. And every protein has a job to perform. Some are structural. They help us build muscle fibers and bone. Others are functional, such as the enzymes that help us break down our food into energy. And while we all have essentially the exact same set of genes, very small variations within and outside around those genes can make us all unique individuals. You also hear the word mutation a lot, and we throw this one around quite casually because it's the common word for something that we call a pathogenic or likely pathogenic variant, which is a change in a gene that causes it to malfunction. These pathogenic variants can cause loss of an essential function. For example, tumor suppressor genes, which are housekeeping genes that help repair our DNA or control the cell cycle, can be lost, which can lead to cancer. Or you can have a gain of function that the cell ought not to have. And these are what we call oncogenes, or cancer-promoting genes, because they have acquired a new ability, such as the ability to migrate to a new location or generate their own blood supply to steal resources from the surrounding tissue. Some variations are actually perfectly healthy, and we don't tend to focus on these. And there are other variations that are of unknown significance, often because they are rare, and we cannot yet determine whether they are causing a gene to malfunction or not. Gene mutations can cause cancers to develop sporadically, and they can cause cancers to develop in a hereditary setting. And we look to Knudsen's two-hit hypothesis. And the concept is that for any tumor suppressor or housekeeping gene, we have two copies, one inherited from our mother, the maternal side, and one from our father, the paternal side. And for most of us, we inherit two normal functioning copies of every gene. However, over time, from exposures in our environment, in our lifestyle, or just age-related wear and tear, sporadically, randomly, a gene can become damaged. Sometimes it is repaired, sometimes it is not. But as long as the other copy is working just fine, we continue to function normally. However, the longer we live, the greater the chance that the second copy of the same gene in the same single cell in our body will also become mutated. And at this point, that cell has lost an essential function and now has the potential to grow in an unhealthy and uncontrolled way to form a tumor. Some of us, however, start off a little bit ahead of the game because when we inherit those genes from our parent, we can inherit one that is already mutated. And that means that every single cell of the body is already one step ahead, which means it will take less sporadic wear and tear to cause damage to the second copy to lead to a tumor. And this means that these individuals have a greater chance of developing a cancer because every cell is already predisposed, and a tendency towards getting cancers at younger ages, as well as a tendency towards developing multiple tumors in different parts of their body. By this theory, all cancers involve genetic damage, but some of that genetic damage is inherited, while other damage is acquired sporadically and is isolated to the tumor itself. We estimate that about 70%, or 7 out of 10 cancers, are sporadic, from acquired age-related damage, as well as damage relating to lifestyle and environmental exposures. About 15 to 20%, or about 2 out of 10 cancers, are familial in that there may be multiple family members with the same type of cancer, but no single gene that we can link those cancers to. And this may be due to the fact that those family members share not a single high-risk gene, but perhaps a number of smaller, weaker genetic risk factors combined with shared lifestyle and environment. And it's only about 10%, or 1 in 10 cancers, that we feel are related to a single high-risk gene mutation that is traveling in that family. When we speak about genetic testing, people often think about hereditary genetic testing, but it's one of many types of genetic testing in cancer care. The first and most common is somatic testing, and this is based on that principle that every tumor is the result of genetic mutations. And if we can identify those acquired mutations in the cancer cells, we may be able to identify weak points within the tumor so that we can tailor treatment to the specific gene mutations that are present. So by isolating cells from the tumor, we can develop a precision oncology treatment plan. Germline genetic testing refers to searching for those inherited gene mutations, which are present not just in the tumor, but in all tissues. So we can rely on blood or sometimes other sources such as saliva or skin biopsy to identify individuals who have an inherited risk factor. We don't want to test the tumor in this case. We know it will have mutations. We're looking for a mutation that is present.
Sorry, I just lost my audio. Is everybody else still hearing those slides?
Stop for us too, actually.
Try again. Pardon me?
It
the audio
Yeah,
is
it
stopped
stopped
on
for
our
you
side
as well.
as well.
Okay, I'm not sure. I just I hit a button and something has just disappeared on us here. So let's get this going again.
It might be paused.
Possibly. Let's try that.
Throughout the body. Minimal residual disease or molecular residual disease refers to looking for genetic mutations that were localized to the tumor but have been shed and are now circulating, floating in the blood. So we use a combination of tumor and blood to identify a particular gene mutation signal. And this can help us detect residual disease after treatment is complete so that we know if we should continue with another line of therapy. And it can also help us detect a recurrence of disease before that person is exhibiting symptoms or before we can identify a tumor on an imaging study. And these three types of genetic testing are currently in practice in our Atlantic provinces. In the future, we may be able to use multi-cancer early detection, which again relies on that circulating tumor DNA floating in the blood, but not from a tumor that we've already identified. Rather, we may be able to detect that mutated DNA before we even know that somebody has cancer to help us improve our early detection over our current strategies, such as pap smears, mammograms, FIT test, and colonoscopy. Another type of genetic testing that we may see in the near future is polygenic risk scores. And this is not looking at single genes that are inherited through a family, but other weaker genetic risk factors, each one not strong enough to cause cancer on its own. But if an individual has inherited many of these polygenetic risk factors, they may combine or add up to a higher than average risk. And this could be helpful in our general population to identify people who perhaps do need more screening than average or earlier screening than average. And these two forms of genetic testing are shaded out here to remind you that these are not yet ready for prime time, but areas of research that we hope will become part of our cancer care plan in the near future. But since I'm a genetic counselor, let's focus on germline genetic testing. Traditionally, this has been ordered by a genetic counselor and offered to individuals who have cancer with or without a family history in a non-urgent setting to help determine whether they are at risk of developing another cancer once this one is successfully treated, or to determine whether their family members are at an increased risk. We also offer genetic testing to people who have never had cancer but do have that strong family history, as well as for individuals where there is already a known gene mutation running in the family. More recently, we are seeing a shift towards mainstream oncology genetic testing, where the genetic test is not ordered by the genetic counselor, but rather by the medical oncologist in the clinic. And this is used when the result may have an immediate impact on treatment. So these are results that we want urgently. And currently in Nova Scotia, we are piloting a project for mainstream genetic testing in prostate cancers, certain high-risk prostate cancers. But we anticipate that this will also be rolling out for ovarian cancer, certain breast cancers, and pancreatic cancer in the not too distant future. And the whole premise is to get that genetic testing closer to home in the clinic for a more timely result for treatment planning. In the future, we may see that this could become useful for other disease sites as well. If you are eligible for mainstream genetic testing based on the specific type of cancer that you have, your oncologist will coordinate that. But for everyone else, they can request a referral for genetic counseling, and this is often done through primary care, the GP, the nurse practitioner, virtual care, and walk-in clinics, but it may also be by referral from a specialist such as an oncologist, surgeon, gynecologist, gastroenterologist, dermatologist, and the list goes on. The genetic counseling team will review your family history, so it's important to complete a questionnaire telling us who has had cancer, what types, and what ages to the best of your ability. We will look through those to identify any suspicious features. If we don't see anything concerning, we will provide reassurance that your family history is not suggestive of a hereditary cancer syndrome. But if it is, we will offer genetic testing, if appropriate, using the best to test model, which means if there is a gene running in the family, not everybody will have inherited it. So it makes sense to initiate testing first on somebody who has already had cancer in the family. And if we find a genetic mutation, we can then extend testing to the rest of the family. This is not always possible, so in some cases we may initiate testing on an unaffected person. Before doing so, however, we will review all the pros and cons of genetic testing. There are certainly advantages and disadvantages to knowing this information, and we want to make sure that you have all of that information to make an informed decision. We will provide decision support, and when that result comes back, we will review the most appropriate screening and prevention options for you based on your level of risk. It would be impossible for me to list all of the eligibility criteria for genetic testing. They do vary from province to province. They are periodically reviewed and updated, and there are simply too many to list. But generally speaking, we are looking for young cancers, people who are diagnosed at much younger ages than average, such as breast, colon, prostate, or uterine cancers before 40, or kidney cancer before age 50. We are looking for multiple cancers. That could mean one person who has had multiple primary tumors over the course of their lifetime, and it's important to distinguish primary cancers from a cancer that spreads from one part of the body to the next. Or we might be looking for multiple affected family members who may have the same type of cancer, or they may have different types that are known to have a genetic link, such as clusters of breast, ovary, prostate, and pancreas, or clusters of colon, uterine, other gastrointestinal, and urinary tract cancers. We also watch out for things that are rare, such as male breast cancer. Breast cancer is very common in our female population, affecting about 1 in 8, but it only affects about 1 in 1,000 men. So right away, that's a red flag. Or we may be looking for very specific features within a tumor. For example, a fast-growing prostate cancer is more likely to be hereditary than a slow-growing one. And a triple-negative breast cancer is more likely to be hereditary than an estrogen-sensitive one. It doesn't mean we won't offer genetic testing to some of those folks, but a particular feature may grant access to genetic testing even in the absence of other family history. And finally, we look for known mutations that have already been identified within that family. I can also never list every possible hereditary pattern or genetic syndrome, but some of the more common inherited cancer syndromes include hereditary breast and ovarian cancer syndrome, and most of us tend to think of the BRCA1 and BRCA2 genes, BRCA1 and BRCA2, but there are 17 other genes that have been linked to these family clusters. Also fairly common are the hereditary colon cancer and polyposis syndromes. Polyposis refers to a tendency towards growing many polyps in the colon. And we have identified 22 genes, including Lynch syndrome, which causes colon, uterine, GI, and urinary tract cancers, and familial polyposis. Familial prostate cancer is also relatively common, and there are 13 genes for this. But there are many more. In fact, the list here is just scratching the surface, and there are over 50 different hereditary cancer syndromes identified to date. So with all these hereditary types of cancer, is there any type of cancer that is not going to be hereditary? Well, not really. Any type of cancer might have a hereditary component, but generally speaking, most isolated cancers, unless happening at a young age, are unlikely to be hereditary. Likewise, most cervical cancers are related to HPV infection. Most cancers over the age of 70 are related to gradual wear and tear. Most skin cancers on sun-exposed parts of the body, such as a basal cell carcinoma on the tip of your nose, and most lung cancers when there is a known exposure, such as tobacco or asbestos. These are unlikely to be hereditary, but even still, there are rare cases where a basal cell carcinoma, a lung cancer, or a cervical cancer might be hereditary. It's important to look at the whole context of the family tree, and if there's ever any doubt, a referral to the genetics clinic can help clarify whether there's any cause for concern. If I've done a good job, I've looked at the family history, I've identified a family that looks suspicious, I've chosen the right test, there's a good chance that we may identify a genetic mutation or a pathogenic variant. So what does that mean? Well, sometimes that mutation may influence cancer treatment options. And so for certain types of cancer, when someone receives that diagnosis, they may be referred to the genetics clinic urgently to coordinate genetic testing before treatment begins. And for this reason, we are now looking to move some of that genetic testing back into the mainstream, into the oncology clinic, to get those results to those patients as quickly as possible. However, the same genetic mutation will not predict the chance of that cancer reoccurring, because that is dependent on so many risk factors, including how early was it detected, how well did it respond to treatment, was the person able to complete the full course of treatment, how large was the tumor, and was it a slow-growing or more aggressive tumor. A germline genetic test result can help predict the chance of developing a whole new cancer. So assuming that somebody's cancer is successfully treated and is not expected to reoccur, we want to know whether they are prone to developing another type of cancer in the future. Or if they've never had cancer, we want to know what types of cancer may they be prone towards in the first place. And that means once a gene mutation has been identified in someone with cancer, we are now able to offer predictive genetic testing to their family members related by blood. And those results can open doors for increased screening that somebody might not otherwise have access to, as well as those preventative options such as preventative surgeries. Even if I've done a really good job, not everybody who receives genetic testing will have a mutation identified. So what happens next? Well, we always have to recognize that this result will reduce the chance that there's a hereditary risk factor in that family, but it will never completely rule it out. So first I will ask, did I test the right person? If there were multiple people who've all had cancer in that family, what if the one I chose happened to have a sporadic cancer? Is it worthwhile to test another family member? Sometimes it is. It's also important to consider that no test is perfect, and even in the genes that we look at, while our technology is very good, we may still miss some types of mutations. And there may also be other genes that contribute to cancer risk that we have not yet discovered. And this means that close family members may still be at a higher than average risk for developing certain types of cancer. So we will still discuss the benefit of increased or earlier screening compared to what the average person would do. And that plan will be based upon the family history. How strong is the pattern in the family? How young have family members been when they've developed cancer? And how closely related is this person to the family members with cancer? Not everybody who is referred to the genetics clinic will be offered a consultation, and not everybody who has a consultation will be eligible for genetic testing. Usually this is because the chance that you carry a hereditary risk factor is low. It's never zero, but we can identify that some people have a low risk, and our thresholds are designed to capture the majority of these families. Even if you are not offered genetic testing, there may be somebody in your family who is best to test. So a family member may be eligible, and the genetics clinic will notify you if this is the case. If you are not offered genetic testing but have a consultation, we will still provide screening guidance based on your family history. And anyone does have the option of considering self-pay genetic testing through research studies, private labs, which require a physician's order, or private genetic counseling services. But I do caution people to be very wary of direct-to-consumer genetic testing that you can purchase yourself. It may not be providing what you think it is. Genetic counseling for Nova Scotia, New Brunswick, and Prince Edward Island is available through the Maritime Medical Genetics Service at the IWK Health Centre in Halifax. We provide bilingual genetic counselors as well as virtual genetic counseling and telephone genetic counseling. Our phone and fax number are here, as well as our website, and there you can find our referral form and provincial referral guidelines. In Newfoundland and Labrador, services are available through the Provincial Medical Genetics Program at the Health Sciences Centre in St. John's. Telephone and fax are here, but they currently do not have their service listed on a website. In the past, Vitalité has offered genetic counseling with Dr. Muna Benamour at the Georges Dumont University Health Centre in Moncton. However, my understanding is that this program is temporarily unavailable. And as mentioned, we will now continue to see an increasing availability of genetic testing in the mainstream oncology setting. It's been great to speak with you today. Thanks very much, and I look forward to your questions.
Thank you so much, Kathleen, for an amazing presentation. I know we've definitely walked away with a lot regarding genetic testing. We have one really great question for you, just to kind of sum up everything. We had a person here in our chat that said that they had applied and had genetic testing done years ago for ovarian cancer, sorry. The data came back without a diagnosis indicator. Given the improvements in techniques, should the testing be redone at this point?
Definitely a great question. So I'm so glad that you asked that. The answer is quite possibly yes, and it depends on how long ago the testing was performed. When I first started doing this, we only had 2 genes for breast and ovarian cancer, BRCA1 and BRCA2, and our panel has exploded. We now have 19 genes that we offer testing for. So we always tell people if your result did not identify a hereditary cause for your cancer, it's not necessarily the end of the story. And I always encourage people to check back about once every 5 years to see if the testing has improved since the last time they were tested. So definitely worthwhile to call in. One of our genetic counselors will be able to look up and see, what was the testing that was performed when you were seen? Is that still the standard, or have we moved on to something bigger and better? At which point a referral back to the program would be appropriate.
Great, thank you so much. We have time for about another question. If anyone has a question that they would like to ask, we'll give you a minute to pop it in the chat. So yeah, is genetic testing offered for osteosarcoma by the oncologist? Is this offered, or should we need to make a request to the oncologist to have this done?
So at this point, in terms of hereditary genetic testing or germline genetic testing for osteosarcoma, it is not something that is available through mainstream, and one that we don't routinely test all individuals with germline genetic testing based on a diagnosis of osteosarcoma, but it can sometimes be part of one of those cancer syndromes. In particular, it can be related to a very rare condition called Li-Fraumeni syndrome. So if there are an abundance of other cancers in the family, and with osteosarcoma, I would say I wouldn't be looking for a particular type of cancer, but a wide variety of cancers could potentially be linked in a hereditary way. But in particular, I would be on the lookout for younger ages at onset. So cancers before the age of 45 to 50. So if that's the case, if there are multiple family members, especially at young ages, I think it would be appropriate to ask for a referral to the genetics clinic. And again, we would review that family history to determine whether it actually looks like there's a potential hereditary risk factor there or not. Like most cancers, most osteosarcomas do develop sporadically, but it's always important to look at that whole family picture.
Great, thank you. We're at time, unfortunately, right now, but if you have a moment, would you be able to just put the contact numbers in the chat there? There's a couple of people asking just for a reminder of the numbers for our genetic testing.
For sure, absolutely, I can do that.
Great. Well, thank you again so much for your time, Kathleen, and your knowledge is abundant in this area. And we look forward to the work that you have coming up in the future.
Absolutely, my pleasure. Thanks very much.
Take care. Thank you.
So I think I've taken over, right? Okay.